When a person experiences unexplainable, intense distress, families immediately face a complex question. Is the root cause spiritual, psychological, medical, or a combination of all three? To describe these symptoms, different disciplines use entirely different vocabularies. One side might describe possession, curses, or jinn disturbance. The other side documents psychosis, trauma, or mania. Yet the lived experience at the center is the exact same. Treating this as an either-or scenario carries severe risks. Assuming an experience is strictly spiritual can cause a family to miss a lethal medical crisis. Assuming it is strictly psychiatric can alienate the patient and ignore their core identity. The immediate goal is not to debate the existence of spiritual realities. The priority is to apply a response framework that protects physical safety, honors personal beliefs, and uncovers any underlying medical conditions. Many help seekers are afraid to mention hearing God or sensing spirits to a mental health professional. They fear they will automatically be pathologized and labeled as mentally ill. Modern clinicians operate on a bio-psychosocial spiritual model. They evaluate a patient's physical body, psychological state, environment, and faith context as a unified whole. This assessment matrix separates safe spiritual experiences from dangerous crises. Clinicians contrast healthy traits, like comfort and intact sleep, with clinical distress markers, like terrifying hallucinations. Command voices and severe sleep deprivation are critical triage priorities, which immediately escalate the situation to a medical emergency. A responsible clinical assessment uses the context of a patient's beliefs to accurately measure when their brain and body are under dangerous strain. Crucially, a responsible assessment does not erase their faith. Therapists will not impose their own beliefs on a patient. However, if a client requests it, a therapist can ethically integrate the client's specific faith and prayer practices directly into the recovery process. Taking psychiatric medication in these scenarios is a biological intervention. It is not a spiritual insult or a sign of weak faith. Medication acts as a tool to stabilize severe symptoms like mania or hallucinations. This stabilization gives the individual the cognitive capacity they need to engage in both spiritual and psychological recovery. This diagram illustrates a collaborative care network. Secular medical professionals work in tandem with non-coercive faith leaders and caregivers, surrounding the patient with equal coordinated support. Integrating these diverse pillars creates a comprehensive safety net that treats the whole person, rather than forcing different support systems to compete. This graphic shows strict triage directives for caregivers to prevent worsening psychosis and trauma. You must avoid mocking the patient, arguing with their reality, forcing rituals, or stopping their medication. Focus entirely on de-escalation. Validate the emotional terror the person feels to protect your connection, even if you do not validate the specific delusion. Seek emergency care immediately if the person discusses suicidal ideation, hears voices commanding them to harm themselves or others, or goes days without sleeping. Families do not have to choose between being spiritually serious and medically responsible. The most effective path to recovery is an integrated, trauma-informed response that prioritizes immediate physical safety above all else.